Hey there, everybody. Good afternoon, or good evening, as the case may be. It is 4 o'clock in the Rocky Mountains, which means 6 o'clock on the East Coast and 3 o'clock on the West Coast. There is one place that you need to be right now. And I am so glad you're here, and that is Fertility with Fink and Friends. My name is Dr. Randy Fink, and I am the clinical director of IVF services here at CNY Fertility in Colorado Springs. It is great to see everybody on a Tuesday afternoon, as we are here every Tuesday at 4 o'clock Mountain Time, 3 o'clock on the West Coast. And gosh, we got a little snow here in Colorado Springs today. And then a few minutes later, it was sunny outside again. So nothing stuck. Nothing stuck. Let's see who we got joining us here. So we've got, of course, a special shout out to the wonderful Brandis Montez, a nurse practitioner extraordinaire here at CNY Fertility in Colorado, who was the first to join me here. We've got, by the way, we've got YouTube and what do we got? Facebook right here. We've got a couple of different LinkedIn as well. We've got a couple of different Instagram feeds. We've got CNYs over here. We've got mine, Randy Fink MD, right here. Leah Schmink is here. Hey, Leah, nice to see you, as well as Brock Tongue. Hello, Tongue family. Mariah and Mags and or Mag. God, I always get that wrong. I apologize. Barbara's here. Good afternoon. Amanda. Witten, Kayla, hello to you. We've got Brittany over here, and let's see what we got on the CNY side. 31 people are here with us on CNY right now. Looks like Gailey Nelson was our first to join, so thanks for being here. Self-explanatory, good name, Shy Davy. Yeah, I was going to say Shy Devil. Let's see, Molly Maroney. Hi to Kristen Barton and Arlene. Jazzy Poo 89. Good to see you here today. The Tater Tot Queen is here with us, and I was worried. Actually, I was concerned that we might not have a Tater Tot Queen, but I am happy to report, yup. Let's see, Liz Carmen is here with us as well. It says, "What are your thoughts on lifting?" Anything lifting? I'm not quite sure what you mean about that. I know about we can talk about cosmetic things. I used to be in that industry to like breast lifts and tummy tucks and blepharoplasties, eye lifts and things. I don't think that's what you were asking. Kristen is here. Oh, good. Cassandra will see us tomorrow for an FET. Outstanding. Okay. So here's Liz's question. What are your you weren't asking about a breast lift. What are your thoughts on lifting anything or anyone over 10 pounds after an FET? Okay, so with a frozen embryo transfer, we usually tell people that we want you to take it easy for the next 2 days. Why is that? Well, because you've got an embryo that's floating around on the inside that's going to be looking for a place to want to set up shop, to take up residence, to implant within that endometrium and start to grow. There is and so people say, well, what do you mean? Bed rest has actually been shown to not be helpful. So we really don't want you doing bed rest. I say, you can live a normal life. I just don't want you doing anything overly strenuous. Like what? Alligator wrestling, skydiving, extreme snowboarding, helicopter skiing, mountain climbing, those kinds of things. I would say probably not the best idea. But as far as picking up your kid, as far as going to work and doing your normal things or walking up steps, there is no reason to think that living a normal life is not okay after doing an embryo transfer. It's just simply want you to take it easy, not do anything overly exerting. People say, well, can I travel? Many people do. Many people go home right after their embryo transfers. And I would say you can. I just don't want you carrying your steamer trunk through the airport because, that's really kind of a physically exerting thing. It's probably not the best idea. But so no breast lifts after embryo transfer, no eyelid lifts, no blepharoplasties. What else we got going on here on the Facebook side? Hello to Josephine and Mary Jo. Thanks for being here with us this Tuesday afternoon. We've got some more questions, but first, also a very special shout out to a very special little lady who is watching the program today, and that would be my dear mother, Emily in Mobile, Alabama, and my dad, who is probably not far away. I got to spend a beautiful few days in Mobile, Alabama, and that came, at just a very stressful time for the folks in Alabama because of the issues, of course, with the Alabama Supreme Court. Our thoughts go out to all those who are dealing with stressful issues over their embryos in the state of Alabama. We are happy to discuss how we can be of service to you if you would like to call us here at CNY. But thanks to Mom and Dad for being such a good host to us, and how wonderful it was to be there. Oh, what else we got going here? Let's see. I got to say a special wave there and hi, of course, to Zinni in South Florida for being with me here. Oh, JM Dots, hi to your mom and dad. How sweet. Thank you very much. Mariah says, if I had a successful FET going the medicated route, but ended in miscarriage, should I try a natural transfer since my cycles are extremely consistent? Well, there's controversy over that about a natural cycle versus a medicated cycle. And on the one hand, you could say, well, you had a medicated cycle and it worked, right? You got pregnant. So if we were going to do something again, why would we want to change anything when we know that medicated cycle worked? The natural cycle is said to have a little lower miscarriage rate, and we know that it also has a lower risk of pregnancy complications a little further on down the line. So I'm a fan of the natural or the modified natural cycle, but there's no problem with doing a medicated cycle because that's what we've been doing really since IVF was invented. So for 40 years, it's been these medicated cycles, and still most of the cycles in the United States are indeed medicated cycles. So I think you are fine to stick with medicated. If you do it a couple times and it's not working out the way you want, then maybe think about changing it up a little bit. How far or how long after childbirth can one transfer again? This comes from Kayla Witten, or Witten Kayla, as the case may be. Generally speaking, we recommend about 9 months is what I would say. I'm generally pretty uncomfortable doing transfers into folks when their babies are less than 9 months old. The number one preventable risk factor for severe preterm birth is a short interconceptual interval. So that means having your babies too close together significantly increases the risk of a severe preterm birth. So that's the thing we're really kind of trying to avoid. Some people say a year, especially if you had a C-section, but there's no specific guidance on that. However, 9 months is what I would say would be the minimum. Ackman's Adventure says, is it okay to wait till July for a retrieval transfer? Should I start sooner? Well, generally speaking, the sooner the better. And I don't know your specific circumstances there, but generally, the rule of thumb is that the earlier we can get eggs from you, the better off we're going to do. And why is that? The eggs that are in the ovary have been there since before you were born. The sperm that comes out today was manufactured 3 months ago, but those eggs have been there since prior since the woman was actually in utero. So over time, those the DNA in those eggs starts to become less stable, and that's one of the reasons it becomes harder for us to be able to get pregnant as we mature. So generally, the earlier we can get eggs from you, the better off. So I think that would be a good thing. I'm a teacher, so I'm out of work. Oh, in the summertime, I see what you're saying. I just turned 34 last week. So, is there going to be a great big difference between March or July at 34 years old? To be honest with you, probably not. I would use the time wisely to be starting on the supplement protocol to help you with your egg quality. So as long as you're waiting, you might as well be trying to fill your tank with the right supplements. And let's see, I saw my friend Barbara from Miami is here from the old office. Hey, Barbara, thanks for being here today. Let's see if we skip over towards we got a bunch of folks asking questions on the Facebook side. So, special hi to Alyssa, who was here today for her retrieval. Good to see you in person, my friend. Thanks for being here, and thanks for watching this afternoon. I hope you got a nice nap after your egg retrieval. Let's see here. Hi to Lisette. Hi to Lindsay. Brittany asked, would a septate versus an arcuate uterus be a reason for implantation failure, and would it require operation? So an arcuate uterus typically is not a reason for recurrent implantation failure. It's kind of a variation of a normal uterus. But a uterine septum is something that can potentially be a problem. And what is a uterine septum? Well, think about your nasal septum. So, we can all look up into my nose here if you want to, but you can do this in the privacy and comfort of your own home. Please be my guest. Use the mirror, not your finger. Words to live by. But the septum is that thing that divides the right nostril from the left nostril. And if we consult again here, our old friend, the uterus, if we had a uterine septum, it would be something that divides the cavity in half. A septum, a band of muscle is actually what it is, or tissue cartilage in some cases, but in the uterus, it's muscle that's dividing the uterus into two parts. So the classic wisdom on that was always, yes, it makes a difference, and we want to remove that septum because it can be associated with recurrent pregnancy loss and with recurrent implantation failure. However, there was a study done in the last 2 years, I believe, that looked at the live birth rate associated with those who have had their septums removed versus those who haven't. And at least in that study, it showed there was no difference in the live birth rate. So it would argue against having to remove a septum. However, certainly in those who have a history of some kind of recurrent failure, whether it's pregnancy loss or implantation failure, it's something I might definitely consider. How do we do that? Well, it's done through the scope, the hysteroscope. So it's a little camera that goes inside the uterus under some anesthesia. We have a little pair of scissors, and they do make that noise. And they go snip, 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 and that band of muscle just opens right up. It's a very, very straightforward procedure to do. It's something that we in the fertility world do all the time, but even your general gynecologist is likely to be comfortable with it. Sometimes it's done under ultrasound guidance. So certainly in our operating room here, since we have the ultrasound that sits right there, usually we do look with it. But removing a septum is very straightforward. The question is, do you have to do it? Well, I would say that the evidence is equivocal on that, because there are some studies that say yes, absolutely, and there are some studies that say it's not necessary. So my guidance would be, if there's a recurrence of something not working, if you just found it and it hasn't done anything to you, then you could probably make an argument that it hasn't hurt anything, so leave it alone. But if it hasn't worked for you and you found that you have this structure, then it might be worth getting that treated. Let's see. Hi to Lindsay. Would food poisoning be anything to be concerned about 2 weeks prior to an FET? So food poisoning is often confused for simple viral gastroenteritis, which is, typically nausea, vomiting, diarrhea kind of thing. In most cases, it's self-limited. It usually lasts for typically no more than 24 hours, but sometimes it can last a little longer depending on what's going on in your world. To have it 2 weeks before an egg retrieval would concern me if you're sick, because that inflammation, pardon me, that inflammation can have an effect on your egg quality, just like having COVID can definitely have an effect on your egg quality. But before an an embryo transfer 2 weeks prior. I would think if it's a self-limited illness that's gone in 24 or 36 hours or so, I think it's probably okay, Lindsay. So good luck there. This looks like Paulina. Paulina Mario says, if all 3 embryos were abnormal at 39 years old, should endometriosis be ruled out? 8 months earlier, 2 of 4 embryos were euploid. Paulina, I would say the answer to that is probably not. So, excuse me, endometriosis, which is, of course, when the lining of the uterus that normally sloughs off and comes out when we have a period, instead of going out the door, works its way up north and implants inside the pelvis. Endometriosis can have an effect. Well, in some women, endometriosis is a symptomatic disease. It causes very severe pain. It causes a pain syndrome, particularly generally with your period, which is known as dysmenorrhea. But in some women, endometriosis is without symptoms. It can be asymptomatic. We think of endometriosis as being a problem for ovarian reserve. So in women who have significant issues with endometriosis, it can have an effect on the number of eggs that remain in the ovaries. It can prematurely cause you to lose some of those eggs. And if you've got a collection of endometriosis that is in the ovary and you have surgery to remove it, that absolutely will lower your ovarian reserve, which we measure through a blood test that's called the AMH, the anti-mullerian hormone, arguably the most important blood test we're looking at for predicting fertility success. Endometriosis also has an effect on transferring embryos and on implantation of those embryos inside the uterine cavity. So, but what I don't think it would have an effect so much in Paulina is on the rate of your euploid versus aneuploid embryos. So what that means is that Paulina had IVF. She had her eggs retrieved. Eggs get mixed together with sperm. That creates embryos. We grow those embryos up to the blastocyst stage, which is typically a day 5 embryo, but sometimes day 6 and sometimes day 7. And then the portion of the embryo that's going to become the placenta is biopsied. And that's called the trophectoderm of the embryo. It's the outside part of the embryo. A lot of times people are worried about that. I don't want my embryo biopsied. What if they accidentally biopsy the arm off of my embryo? Understandable, but the portion that gets biopsied is the part that becomes the placenta. It's the outside part of the embryo. So those cells go off to the laboratory, and they are able to test the chromosomes of the embryo. If those chromosomes are normal, that's called a euploid embryo. If those chromosomes are abnormal, that's called an aneuploid embryo. And that process is PGT-A, pre-implantation genetic testing for aneuploidy. The most common reason that someone who does IVF doesn't get pregnant. So let's say that she makes those embryos, a couple makes those embryos, and they get placed inside, but then you don't end up with a positive pregnancy test. Really, by far and away, the number one reason for that is that it's an embryo issue. It's a problem with the chromosomes in the egg that result in an abnormal embryo. Now, it can also be a sperm problem, but more commonly it's an egg issue that's really based on age. So by 39 years old, Paulina, I would expect that probably about 50 to 60% of your eggs are going to be normal, no more than that. So I think the aneuploid embryos that you have there are most likely as a result of age. What can we do about that? So that's an issue that we call egg quality. And there are some things that we can try for egg quality. Omnitrope or growth hormone is one of those things. There is a list of supplements I can give you that's specifically for egg quality. There is we often use metformin. Metformin functions the same as a supplement known as myo-inositol, which is something that you can buy at the store. That's typically 2 grams twice a day, or 4 grams divided up, over the day. Um, um, and there can be some things that we can do as far as medication goes that may also improve egg quality. But I don't think that has to do with endometriosis. Now, we think about endometriosis if you're doing a bunch of transfers and they're not sticking. So let's say that you had all these euploid embryos. That first euploid embryo gets you a 65% chance of getting pregnant. By the time you do your second embryo transfer, that gets you to about an 88% chance of getting pregnant. And by the time you do your third euploid embryo, you're looking at about a 95% probability of being pregnant. So that's pretty doggone good. But let's say that you do those 3 euploid embryos and you don't get pregnant, then we start thinking, do you have endometriosis? And I wouldn't wait till the 3rd embryo to try to find that out. I would start trying to evaluate that really after the second embryo transfer of a euploid embryo that didn't work. So hopefully that's helpful there. Liliana asks, if I do a hysteroscopy, will I still need to do an HSG and a saline sonogram? Well, a hysteroscopy is the diagnostic procedure for the screening test of a saline sonogram. So if you do a saline sonogram, you don't need to do a hysteroscopy. But if you do a hysteroscopy, then you don't need to do a saline sonogram. I don't typically necessarily recommend an HSG for folks who know that they're going to be doing IVF, but certainly if you're trying to do an intrauterine insemination or an IUI, then I think you need to do an HSG because, of course, we want to know that your tubes are open. But if you've done a hysteroscopy within the last year, the saline sonogram really is unnecessary because you've already evaluated that uterine cavity. FK Malik says, what's the success rate for a 30-year-old fertile woman doing IVF for gender selection? Well, generally, it's going to be very high. At 30, I would suspect that probably close to about 80% of your eggs are going to be normal, which means that 8 out of 10 of your embryos, and of course, this is a generalization, are going to be normal euploid embryos. Now, once you do that testing, that PGT testing, and see that your embryo is normal, we know that that one's going to give you a 65% chance of pregnancy, as we just talked about. Now, when you're doing it for gender selection, it means that you've got 2 things that you have to land on here. You have to land on a euploid embryo, and you have to land on an embryo that is of the gender that you are seeking. And it's really completely by chance. There is no evidence to show that we can have any significant impact on the ability to select gender based on sperm or based on something that we do in the lab to create the embryos. So hopefully that's going to be a fruitful journey for you there. How long should I be off phentermine prior to an egg retrieval? Hi to Hunter. How long should you be off phentermine? Well, phentermine has a reasonably short half-life. So I would say if you want to be safe, be off of it for a month. I have not seen any data that shows that it has any effect on egg quality. It does function in the body as a significant stimulant, as I'm sure you know. So I would certainly say at least the week before, because you don't want to start mixing those stimulants along with anesthesia and such for an egg retrieval. Oh, thank you, Shy Davy. Thank you for the pronunciation. I appreciate that. Oh, well, let's see what else is going on here. Today was my transfer. IVF, what symptoms? That comes from Evelyn. Today was my transfer. IVF, what symptoms? Not sure what you're asking about there. Here asks laparoscopy before egg retrieval or after with a 2.6 AMH. So that's a very good ovarian reserve level. Laparoscopy for fertility purposes has not been shown to routinely be helpful in the general population. So, assuming, maybe there's some other reason that you need to have a laparoscopy. So let's say that you've done some imaging and we found that you have a hydrosalpinx, that there's fluid in the tube. And we need to take care of that because we don't want that to be there when you're going to do an embryo transfer, because it can affect that fluid washes back into the uterine cavity and can be toxic to the embryo. Well, I would tell you, do your egg retrieval first. Because again, going back to that mantra, the sooner we get the eggs from you, the better quality those eggs are going to be. And even if that's just for a few months, ideally, the sooner we get the eggs, the better off we are. So here I would say, if you needed a laparoscopy, and I don't know that you do your retrieval first, and then sort out that laparoscopy business later on. Let's see what we got. CM Russo, I have two embryos that are euploid. One's a 4AB and the other is a 4CC. What is the success? What's the difference between the success of the two? So you ask a good question there. And what's being asked here is, all right, so we have two known chromosomally normal embryos. Once we have a chromosomally normal embryo, the grades don't matter anymore because you're at a 65% probability of one of those embryos getting you pregnant. So the most important thing that we can try to figure out is which of the embryos are chromosomally normal. The grading of the embryos really is a beauty contest. Now you've got that 4AB, that's a better graded embryo. And so if you ask the embryologist, they would say that's the one you transfer first if the gender is what you want. But in theory, those should, assuming they're both day 5 embryos or day 5 or 6 embryos, they should have a pretty equivalent pregnancy rate. So let's talk just a little bit here about this embryo grading business, because it always comes up and it's a source of so much stress in people's lives. We've all been to high school, right? So we all know what it's like to get those grades sent home to your parents that maybe you aren't so proud of. And I am happy to say, and I am proud to say, that I was in the half of the class that made the top half possible. So what are those guys doing now? And that's what I want to know. What are you doing now? Look at me. Okay. Well, so when you get a grade in school, that's telling you where you are relative to the rest of the class. And if you get the best grades in all of your classes and in any class, well, you are the valedictorian of your class and you get to give a speech at graduation, and that gets some extra pictures taken of you and bragging rights. And that's about it. The grades in our school system are designed to tell us where we are relative to the other people. What grading in the embryo world was designed for was to see if an embryologist could look under the microscope and describe a series of features to try to be able to show, which one of these embryos is going to be chromosomally normal? Can we tell from looking? Or is there something about an embryo grade that's going to show us which of the embryos are euploid? And the answer to that is no, we can't. If any of you have done PGT, and obviously some of you have, you probably saw that there's a wide variation in whether, you may have a very highly graded, beautiful embryo that has multiple chromosomal abnormalities. And you may have a poorly graded embryo that is the only chromosomally normal one in the bunch. So it doesn't correlate with which ones are going to be normal, and nor does it tell you which of the embryos will be successful. I can't tell you the number of babies that I've been able to hold in my arms and look at and coo at and get pictures taken with that came from embryos that people said, oh, these are poor quality embryos. These are low graded embryos. This probably isn't going to work. I don't even know if I should transfer this embryo because its grade isn't very good. Not the fact. I would be willing to bet that there's at least some of you watching our broadcast today who have had that same experience. That you had a poorly graded embryo that you believed, it's probably not going to do anything, but guess what? It gave you a baby. So CM Russo, you can transfer either one of those, and in theory, they should give you an equivalent response. What time is it? 4:30. Gosh, it's half past the hour here in Mountain Time, 6:30 on the East Coast. And you are on Fertility with Fink and Friends, as we are every Tuesday afternoon. Gosh, we got a lot of good questions here, and I'm going to try to get to all of them. Never get to all of them, but I sure am going to try. Appreciate you being here today. Let's see. Trying to lose weight. Yes, indeed. Would a prolonged this comes from New Attitude 08. Would a prolonged immune protocol help to prevent repeat PPROM? I had my miracle IVF baby 7 weeks ago, but suffered PPROM at 17 weeks with the reseal. Wow. Okay, so PPROM stands for premature preterm rupture of the membranes, or it may actually be preterm premature rupture of the membranes. Either way, you break your water before you're supposed to, when you're preterm and before you go into labor. New Attitude, I would say that is I'm looking at that picture. Is that who I think it is? Is that really you? Wow. If I can't quite see it, but I think I know who you are there, my friend. Okay, so at 17 weeks, you got a miracle baby, and there's no question about it, because most obstetricians and most specialists would say at 17 weeks, the odds of the bag of water resealing to result in fluid reaccumulating around that baby so that the baby can continue to grow, that the lungs can continue to expand, the odds of that happening are very, very low. And so most specialists at 17 weeks would tell you you need to deliver and we need to end the pregnancy. So I am so happy for you that you had your baby after a PPROM at 17 weeks. Most commonly, preterm premature rupture of the membranes happens, in women who are at a viable gestational age. Is it most common? Actually, I don't know if it is or not, but in that situation, we usually put you in the hospital, and there you stay until ultimately either you go into labor or we decide to deliver you. We continue to test the fetal well-being. We make sure that you're not getting an infection. So to answer your question, would a prolonged immune protocol help to prevent the recurrent preterm premature rupture of the membranes? There is no evidence to say it would. And there are varying theories on what causes those membranes to rupture prematurely. And it is really thought to be some low-grade infection on the inside, because indeed, once those membranes are ruptured, the vagina, which is loaded with bacteria, that bacteria has the ability to get up inside the uterus. It often causes an infection called chorioamnionitis, which then results in labor or the need to deliver. So now, in your case, I think that you probably have some underlying, if that's really who your picture is there, you have some underlying health issues. And I think that they were probably in some way related there. But congratulations. Oh, my heavens. What an unbelievable miracle and a blessing to have a 17-week rupture of the membranes that then reseals and results in a term delivery. Congratulations. Hi to Ray in Denver. I like the name. Mrs. Pittman is here too. Macy Clark says, we have a high-level mosaic in our PGT. Should we use it or use our untested embryos? All right, so let's talk about this mosaic thing, because this too is a constant source of stress for people. When we do PGT testing, All right. So when we biopsy those embryos to figure out which of the embryos are chromosomally normal, um, we can get some different outcomes. We can get a euploid embryo. Euploid means it's a 46 pairs, 46XX or 46XY, 23 pairs of chromosomes. Chromosomally normal embryo, at least in the placenta where it's been tested. You can get an aneuploid embryo, which means that it is not believed to be a normal chromosome embryo, even though 15% of the time that embryo can still give you a normal baby. So what else? We can get an embryo that comes back and says no result, which means that the DNA degraded and they weren't able to test it. A no result embryo is the same thing as an untested blastocyst. We can get a mosaic embryo. What does that mean? A mosaic is a combination really of two different kinds of cell lines. One's normal and one is not. When they find this, again, they're biopsying from the placenta. So when we have a euploid embryo, we said that one gives you what percent did I say? Were you paying attention? How much? What's the percentage of pregnancy with a euploid embryo? 65%, right? So we have a 65% probability with a euploid embryo. If we have an untested blastocyst, like a day 5 embryo, that gives us about a 30% chance of a pregnancy. The mosaic embryo gives you roughly about a 40% chance of pregnancy. So it's not quite as good as a euploid embryo, but it's still better than an untested embryo. There is a slightly higher risk for miscarriage with a mosaic embryo, but if that embryo implants and grows, then it has nearly every possibility as your euploid embryo of giving you a normal baby. So it is still a good embryo. Frankly speaking, it has a better chance of getting you a pregnancy than your untested embryo. So what would I do? I'd probably use the mosaic. Now, again, you have to face, well, there's a slightly higher risk of miscarriage, but assuming it sticks, it's going to give you a normal baby. They're believed to be normal. So that is actually good news. It's a step in the right direction. Now, we have to be careful with those mosaic embryos when they are things like a trisomy, like a 21 mosaic or a 13 or an 18, because those may be more associated with problems. But Macy, I'd say that's a pretty good place to be in. Let's see what we got here. Peachy Nix, can you speak on an embryo graded 1-3? So that's going to be a day 3 embryo. And what it's saying is that it is an embryo that is believed to be of lower quality. So does that mean that it can't get you a baby? All day long, our embryologists will tell you these embryos that are said to be of low quality can absolutely 100% still get you pregnant. Now, would that be the first one that I would transfer? No, generally speaking, what the embryologist will do is we'll say, well, which one should we transfer? They're trained to look at those embryos and pick the prettiest one, and that's the one that's going to get transferred. Unless we've tested them and we know they're chromosomally normal, the grade shouldn't matter too much there. Self-explanatory says, for someone with a hydrosalpinx, do you recommend I remove my tubes first or do an egg retrieval first? I would say do that egg retrieval. The tubes are not going to get in the way of doing the egg retrieval. And again, the sooner we get those eggs from you, the better off we're going to be. So let's try to get the eggs as quickly as possible. Get the eggs, make the embryos, do another cycle of IVF if you need to, do as many cycles of IVF as you need to. And then before it's time to think about doing an embryo transfer, that's when you get the tubes taken care of. Okay, I think that's very important words to live by. Liz is here, 12 weeks pregnant tomorrow. Congratulations. First transfer was done at Colorado Springs on December the 26th, which happens to be my father's birthday. Coincidence? I think not. Very wonderful news. Glad to hear that. KB baby number one is a CNY baby ready for number two. How long should we try naturally before deciding to use frozen embryos? So it really depends on, what was the reasoning for doing the IVF in the first place. Because if we know that there's a tubal factor, that the tubes are blocked, no sense in doing, no sense in trying on your own at all, because the odds are it's not going to work. If it was a significant male factor, that the sperm count is, 2 million or something, or there's no sperm, don't try it on your own. Go ahead and do the FET. So I think, some of that depends on age, KB, and what the reason was initially for your IVF. Can I drive home the next day? It's a 20-hour drive over 2 days. Well, is that the next day after a retrieval or after an embryo transfer? So yeah, you can drive home after a transfer. The day after an egg retrieval, I wouldn't recommend that you spend 20 hours in the car. You're going to be bouncing around. You're going to be uncomfortable. You're going to want to pee. It's probably, well, actually, I take that back, because there are plenty of people who the day after an egg retrieval do drive home. So I'm thinking about you behind the wheel, and if you're alone in the car, I don't want you driving for 20 hours the day after an egg retrieval if you're by yourself. But let's say that you brought the significant other, you've been here together, you did your retrieval, it's time to go home. Yes, it is okay to go home, even for 20 hours the next day. And yes, it's okay if it's a transfer that you've done. Sea Shelly Travel. I thought that I was going to say something about seashell. Sea Shelly Travel. I like that name. You get a special wave. Hi to you. Netaboo. Good evening to you, my friend, and Wildflower. My IVF transfer. Oh, okay. This goes back to that question from before. What symptoms should I expect after an IVF transfer? To be honest with you, probably not really anything. It's a pretty benign little procedure. If you took the Valium at the time of the transfer, then you're probably going to go home and take a nap afterwards. That's used as a muscle relaxant, so that to help prevent spasm of the uterus. But otherwise, really, you can go on your normal life. Most people don't have any significant degree of cramping or other kinds of problems like that. So, best of luck, Evelyn. Alexis asked if someone was on an immune protocol and is switching to natural, should they continue on that protocol? I would say, Alexis, there is no harm to staying on an immune protocol if you have switched to doing a natural cycle. It's probably more than you need, but there's certainly no harm to doing that. Let's see, why does egg quality change over time? Well, that has to do with that DNA that's in the egg. So just like we age and the signs of aging become obvious, the gray hair, the balding, the wrinkles, all these other things, the getting cranky, not that I would, know anything about that, but our DNA is changing. It's constantly changing. Our cells are dying. That the natural cell death is what's called apoptosis. And so we're constantly turning over cells. The easiest way to imagine that, other than looking in the mirror, is that, if you take, go back to second grade, you remember if you took a toothpick and you scraped it on the inside of your cheek, you'd get a bunch of cells that then you could see under the microscope, and that we're constantly sloughing off. These cells are skin cells, cells inside the gut, every place. And so we're turning over these cells. DNA is getting older. DNA is supplied to us as what's known as a double helix. It's this little wrapped up molecule. I can't really do a double helix, something like that. It is a double helix. And so some of those little pairs of DNA start to degrade. The helix starts to unwind. Some of the connections start to get messed up. They're all different types of degradation of DNA that we had to learn back in medical school. And I'm sure I could write a book on it now if you wanted me to. Um, but that's the reason. So as we mature, there's two things that's happening. One is that we're losing more and more eggs because, again, by the time we're 35, we're losing about 10,000 eggs a month, which is hard to believe. But that goes to show you there's a lot of eggs in the ovary, generally speaking, to begin with. So one, the quantity of eggs is going down, but two, that DNA is becoming less stable over time. And that's really the reason why. Now, the interesting thing is that, as humans, we have DNA repair mechanisms. So that's why every little spot on your skin that you get from the sun doesn't become skin cancer, because our DNA repair mechanisms can repair that damaged DNA. And so sometimes that can happen at the level of the ovary. It can happen in the embryo. It can happen in the placenta. There's believed to be a second insult that can happen to that DNA, typically in the 2 to 3 months before that group of eggs is being recruited to get ovulated. So in IVF terms, well, in natural fertility, you're going to release one egg. You ovulate, you get a whole group of them. One of them emerges as what's known as the dominant follicle, and it goes on to get released to get ovulated. In IVF, we're trying to get all of those eggs. So instead of just one to grow, we want that whole cohort to grow. But that group that has been destined to grow in the 2 or 3 months prior to whatever programming is taking place, that's going to tell that group of eggs that you're going to be the one to grow. That's the second opportunity that we may have to be able to try to repair some of that age-damaged DNA. And that's where those supplements come in. Now, I do want to, we've got about 15 minutes left. So I want to say a couple things just about supplements. I do have a list of supplements, which I'm happy to provide for you. Email me, or rather through Instagram at Randy Fink MD. I'm happy to send you that list. CNY Fertility has some very good supplements, but the evidence-based protocol here comes from the book. It starts with the egg. I read it, so you don't have to, but you're welcome to if you want to. I totally lost my train of thought there. I don't know where I was going with that one. Right, the supplements. I do want to mention, what are the two most important supplements? Well, let's call it three most important supplements. So one's a prenatal vitamin. And what do I think of prenatals? I think any prenatal you're on is fine. So please do that. Please be on a prenatal vitamin. The second most important supplement for anyone who is trying to get pregnant, whether you are trying at home, whether you're doing IUI, whether you're doing IVF, it is CoQ10. Coenzyme Q10 functions in the body to, it does a whole bunch of things. So let's just say CoQ10 is a very important thing. How much CoQ10 should you be taking? There are two different forms of CoQ10. One is called the ubiquinol form. Ubiquinol is the form that exists in the body and is the most easy to digest. So if you're using the ubiquinol form of CoQ10, you need 400 milligrams divided up twice a day. So that's 200 milligrams, once in the morning, once in the evening. There are other forms of CoQ10 that are not ubiquinol, but confusingly enough, they are called ubiquinone. The ubiquinone form is not the type that exists in the body, but it's fine to take if you have it. You just have to take a little bit more. And that would be 600 milligrams divided up twice a day, or 300 milligrams in the morning, 300 milligrams at night. So it's either 400 or 600, so 200 and 200, or 300 and 300, depending on whether you're on ubiquinol or the ubiquinone form of CoQ10. If you have a diminished ovarian reserve, so that, let's say that your AMH is less than 1, or let's say that you are over 40. Some people would even say 35, but I say 40. Or if you've had an experience with IVF where you haven't performed as well as expected, and those we would call, I hate to use it, it sounds judgmental, but they say poor responders or low responders. Maybe that's a better terminology for it. So if you're a low responder to IVF, if you're over 40, or if your AMH is less than 1, the other most important supplement is DHEA. DHEA. Now, that's not to be confused with DHA. DHA is fish oil, and it's a damn good thing to take as well. But DHEA is a precursor to testosterone. It's involved in the cascade of testosterone, but it has something to do with the signaling of the of the egg and how we go to repair it. The ideal initial dose of DHEA is 25 milligrams 3 times a day. Now, I recommend that we do test those levels because sometimes people's levels can get very high, but we actually do want them pretty high, even if it's up to 100, or rather up to a level of about 350. I would say that that's a good level. Some people will test it and they're at 650 or 700, and I say, okay, well, we can drop it back. Some people might say, well, I'm more comfortable starting on it once a day. I mean, that's fine too. But the effect of the DHEA is additive. So over time, it continues to help you and get better and better. The blood test that we do for that is not DHEA. It's called DHEAS, which is DHEA sulfate. And so that I think is definitely worth looking at. So CoQ10 for everybody. If you're over 40, AMH less than 1, or a low responder, then please do add to your prenatal vitamin and your CoQ10 some DHEA. There is a whole list. We can do a whole talk on the supplements if you'd like sometime, but then that means that we don't get to answer all these wonderful questions. Pedro Baby Dream, DHA, no, DHA is fish oil. DHA and EPA are what are known as fish oil or omega-3 fatty acids. We're talking about DHEA, and that is a different animal. Mandy Beers, I had a baseline appointment last week so I could schedule an HSG and a saline sonogram. She said she thought that she saw fluid in one of my tubes. My HSG couldn't be scheduled until late March. Is it common or uncommon for fluid to be found in a tube, and can it go away on its own? When I read online, the only info that I can find is about a hydrosalpinx. Does fluid always mean hydrosalpinx? Yes, it does. So fluid in the tube, Mandy, is a hydrosalpinx. Hydro means fluid, salpinx is tube. So sometimes when you do an HSG, it can give you a false positive. Ultimately, if it's a clinically significant hydrosalpinx, we can usually see it by ultrasound, but definitive diagnosis can also be with an MRI. So usually when that fluid is in the tube, it will not go away on its own. So I do think that is worth evaluating. Should a good prenatal have B12, or should it be taken separately? Almost all prenatals will have something in the B complex, and B12 is one of those things. B12 can prevent certain types of anemia, something that is known as pernicious anemia. B12 kind of gives you energy. B12 helps your metabolism and helps to mobilize some fat. So every prenatal is going to have B12 in it. I do not feel like you need to take extra B12 in your pregnancy. Let's see here. Oh, hello to Alexis down in Miami. I didn't see that you joined a little while ago. And oh, look at that. Cockatoo and Bassett are here. Two of my favorite people, both the Cockatoo and the Bassett. I'm getting ready to start on an FET. This comes from Gina Bradley, double donor embryo. Well, I don't see there's a question there, but good luck to you on your FET cycle. What add-ons do you recommend for a modified natural FET? So the add-ons really have to do with, so first of all, I do think, so there is actually a list of supplements that are used for embryo transfer. The one for sure that's added on is um, L-arginine, which should not be taken, underscore, bold, italic, not be taken for egg quality, excuse me, but can be taken for embryo transfer. It depends there, Brittany, on what immune level you're on. So typically, we feel that the immune system almost always has some effect on the ability to get pregnant. And so we generally recommend some level of immune protocol for really everybody who's doing some kind of treatment. The typical immune protocol for me is immune level 2. If you're doing an IUI, then we can say immune level 1. But if you're going to do IVF with an embryo transfer, immune level 2, and that includes some things like low-dose naltrexone, that includes some prednisone, certainly your prenatal, a baby aspirin. We give you a little bit of antibiotic to take because we're going to be dragging a needle through the contaminated vagina into the sterile pelvis. And what else? Some intralipid, which is a fat infusion that's very helpful for suppressing natural killer cells, which is a type of immune response. And what else? We like to do HCG washes. That's a good thing as well. So I think that is that's kind of the basic of immune protocol level 2. Now, these things are all voluntary. There's some people who say, I don't want to take all those things. You certainly don't have to. But it's one of the things that CNY, we call that reproductive immunology. It's one of the things that we kind of routinely do. Hello to Melissa. How long does recurrent pregnancy loss and DNA karyotyping take to come back? Still waiting from February 17th. It often takes about 2 weeks to get those results back. So should be any old time now, Melissa. Good deal. Let's see. We've got a few more minutes. Let's see what all we can get in. Crystal says, hey, I'm late, but I hope you're having a great day. Thank you. I appreciate that. Hi to Alexis and to, hey, Equestrian. Can you talk about when it's appropriate to add intralipids to a protocol? When and how many infusions are recommended? Do I need them for both retrieval and transfer? History of a blighted ovum. So a blighted ovum is a situation where the placenta exists, but the embryo, the baby inside, does not. So that's what's called an anembryonic pregnancy. And that is a genetic issue. It is not an immune issue. So it will not have anything to do with that immune protocol. However, I would think, for really just about anybody, at least one dose of intralipid is a good thing. It's usually done the day or so before, 1 to 2 days before embryo transfer. It can be done weekly. Sometimes folks have a hard time getting it done, finding a place to be able to do infusions. But at least the day before, 1 to 2 days before, sometimes it can also be done on the day of transfer. So yes, I do think it's helpful there. Let's see what we got here over on the Facebook side. After an SIS is normal, this comes from Josephine. When do I start the medication or what's next? Well, so if you've had your consultation and we have a plan in place, then usually after you've done that saline sono and you've done your blood testing, we're generally waiting to hear from you on cycle day 1. So if you're being followed in one of our local offices, you would notify that local office nursing team, or if you're a global patient, you would notify global travel. The best way to communicate by far is always the portal, because getting on the phone can be really quite maddening, as I'm sure you have experienced. So send a portal message that you're cycle day 1 and that you're ready to start. I just got a call this comes from Jessica from the Bundle Pharmacy, and they have a few immune medications on my protocol. What is Neupogen for? I'm 25, unexplained infertility, no previous pregnancy or miscarriages. Well, I generally don't order Neupogen in that scenario, but some people do, because if it's unexplained, it could be that there is some problem with that there's some autoimmune reason there, Jessica, that you're not getting pregnant. So what Neupogen does is that it increases your white blood cell count, and as you increase your white blood cell count, it helps to combat sometimes some immune or infectious issues, whether they be acute infections or low-grade infections that may be smoldering, that can kind of prevent you from being able to get pregnant. So it's up to you whether you want to use it. Neupogen is an expensive medication. It was ordered for you, so I'm sure someone thought it was a good idea. Let's see. I think we got time for one more over here. Exo Davis, 39, 40 in September. The estrogen level is 41. The FSH is 4.5. The AMH is 7.5. The dye test was also good and clear, but still not pregnant. Would you recommend starting with IUI or going straight to IVF? So by 40 years old, I would go straight to IVF, because the success rate with an IUI is never going to be very high, and is generally not going to be better to get you pregnant than with home intercourse alone. Once we're above 35, you start getting very rapid diminishing returns on an IUI, and IVF becomes really a better procedure. Even still, again, IVF can give you a 65% probability of pregnancy in any given embryo, whereas an IUI may give you, assuming that that you've got good egg quality there, perhaps a 9% probability per cycle. So an order of magnitude higher, but at 40, I would say let's think that IVF is probably the better, the more reliable for you. Hey, folks, looks like we're going to be out of time today. I think the social media is going to kick us off the feed here. So let me just say how great it is to be with you. As always, we're here every Tuesday afternoon at 4 o'clock Mountain Time, 6 o'clock on the East Coast, and 3 in the West. Until next week, remember my mantra, which is that lead with kindness, move forward with love, and always, every day, have hope for tomorrow, because tomorrow can bring all kinds of magic and wonderful things. This whole fertility business is not your book. It's not your novel. It's not the story of your life. It is one little chapter. And what we're doing is trying to help you rewrite it. So until next week, thanks for being here. I'm Dr. Randy Fink. God bless you all. Good night. See ya.